See now the necrotizing pancreatitis. Necrotizing pancreatitis is, you can see it as the sequel of the severe pancreatitis. So let's remember the severe pancreatitis. Severe pancreatitis is the classic presentation of pancreatitis plus hypotension, hypocalcemia, hyperglycemia, metabolic acidosis, leukocytosis, and hypoxia. So the necrotizing pancreatitis would be the necrosis of the pancreas. So the diagnosis would be with the CT scan, and the necrotic tissue could get infected. So we need to give antibiotics. So remember that the indications for antibiotics include severe pancreatitis with necrotic tissue. So usually necrotic pancreatitis or pancreatitis with cholangitis. Alright, so if the CT scan reveals more than 30% of necrotic tissue, then we need to do a biopsy, and we will give the imipenem. So more than 30% of necrosis, the antibiotic plus the biopsy. And if in the biopsy we find the infected necrotic tissue, then we do a surgical debridement. Now the surgical debridement, we usually perform it like 4 weeks after the presentation, because we want that the necrotic tissue be very demarcated from the normal tissue, so that the surgery could be done easier, and we remove exactly just the necrotic tissue. So for that we wait for around 4 weeks if the patient doesn't develop sepsis. So even though the necrotic pancreatitis is more difficult to manage and is a sequel of severe pancreatitis, and the treatment is necrostomy is the surgical debridement of the necrotic tissue, we prefer to do it 4 weeks after, because we want to eliminate that we want to have delineated the necrotic pancreatic tissue from the normal tissue. Now the CT scan is the best way to assess the severity of the disease. If we find more than 30% of necrotic tissue, we need to do biopsy and then surgical debridement if we have infected tissue. So the severity is assessed with the CT scan as well as the management. And the criteria for operation, for surgical operation, is made with the Ranson criteria. Remember, Ranson criteria include the criteria at admission and 48 hours after admission. So in admission, we have certainly the age of the patient greater than 55, but that's not something that is of the event, that is something that the patient lives with, so I will not put it. The aspartate aminotransferase greater than 250, lactate dehydrogenase greater than 350, glucose more than 180 milligrams per deciliter, and the leukocyte count more than 16,000 per cubic millimeter. This, for admission, means a very severe pancreatitis, and we maybe need to do operation. And the 48 hours criteria includes the calcium being less than 8 milligrams per deciliter, the metabolic acidosis with acid base deficit greater than 4, the liquid sequestration more than 6 liters, and the falling on hematocrit more than 10%. This is because necrotizing pancreatitis, if erodes some vessel, then can hemorrhage, and the hemorrhoid will present with the hemorrhagic pancreatitis, and the hemorrhagic pancreatitis will present with falling on the hematocrit, and is this what distinguishes the hemorrhagic pancreatitis from the normal edematous pancreatitis, in which the patient has a hemoconcentration because of the loss of the liquids. Alright, so these are the ransom criteria and aids on the assessment of surgery, but not on the severity. The severity is assessed with the CT scan, as well as, in a sense, the management. The signs of curling and gray Turner are signs of pancreatitis. So we will see hemorrhage either on the umbilicus or on the flanks. The bluish discoloration around the umbilicus in the periumbilical area is the curling sign, and the bluish purple discoloration of the flanks is the gray Turner sign, and is seen in hemorrhagic pancreatitis. Other complication, now let's say complication of complication, that is the hemorrhagic pancreatitis needs to be monitored with CT scan daily, because this can end in a abscess formation. And remember that the abscess formation, the abscess needs to be drained, usually by percutaneous drainage, but if there is extensive lesion, then the drainage would be with open surgery and surgical debridement. So in a sense, the necrotizing pancreatitis can lead to a hemorrhagic pancreatitis, and the hemorrhagic pancreatitis can lead to a suppurative pancreatitis. The abscess can arise in a edematous pancreatitis or in a necrotizing or hemorrhagic pancreatitis.